For today, we want to celebrate the contribution of MLI in epidemics, and that's what we are going to discuss today. The celebrations of MLI will happen in November. I think, Simon, you will say more about that after Damari's presentation. But most importantly, like I mentioned when we were planning the celebration of CHS at 100, this is going to be a personal celebration. Each of us needs to think, what is it that we are celebrating about the Lung Institute? That is in addition to other objectives. We want to raise awareness, we want to do many things, but since this is a celebration, each of us needs to think in the different ways the Lung Institute has touched us. It may not have touched you as a person, but it may have touched your community, your university, your country, and the world. So that way, everyone will be able to show up on 27th November with their champagne to celebrate. The celebration is going to be made, if the chair of the committee can allow me to use this time to mention 3 things. One, there will be a real celebration, a dinner of eating and drinking and real celebrating. Yeah? And the committee is planning this. Secondly, we are going to have a scientific symposium, and we invite you to submit abstracts and papers. And the third activity, we are going to unveil the foundation stone of the MRI home that is currently under construction here at Mulago Hospital. And I thank the hospital for allocating us the land for this project. So those are the 3 things which we need to keep at the back of our mind. For today, I will not come back after the presentation. Simon, as chair of organizing committee, will make your remarks and then we start the presentation. But for today, we really want to see what MRI has done in 10 years on epidemics. Strategically, I have put on this field jacket. I know, Winters, you have yours as well, and others, because in the 10 years, MRI was able to birth something called ICER, which strictly works on what? On epidemics. And so far, Winters will tell us we have had some milestone in that area. So members online and those ones in the room, I want now to hand over to Damari to make a presentation, after which Simon will make some remarks and we'll go into the presentation. I wish you good deliberations. Damari, over to you.
Thank you very much, Professor. So I will not waste any more time. I'll just tell you a little bit about the background of the Lung Institute. For those who are not aware already, these are some of the pictures from those founding moments. You might be able to recognize some of the people in these pictures. So in 2015, with a handful of visionaries and a signed memorandum of understanding between Makerere University and the Lung Consortium International, Makerere University Lung Institute was born. And then a couple of years later, in 2019, it was officially inaugurated. But it's going to be about 10 years this November of the of impact in lung science and lung health from the Makerere University Lung Institute. And so the foundational statements, these are things that you've probably seen already, that the mission of the Lung Institute is to conduct high quality health research that integrates disease prevention, clinical care, and training in sub-Saharan Africa. And this is really towards an Africa with healthy lungs. These are our core values. And the Makerere University Lung Institute executes this mandate through research and innovation, clinical service, and training and education. This is Professor Bruce Kirenga, who is the founder and director for the Institute and the current principal for the Makerere University College of Health Sciences. I think you have seen him around. If you've not seen him on the Hill, at least you saw him a few minutes ago as he introduced this webinar. And this is the MLI leadership. You can see it is transdisciplinary or interdisciplinary for that matter, and includes local and international researchers. So what are we celebrating as the Makerere University Lung Institute? We are really celebrating growth over the last 10 years. We have seen hundreds, well, over 100 peer-reviewed articles, plenty of trainings conducted, patients attended to, enrolled into care and followed up. And we have over 700 staff, and you can see that gender balance is something that is emphasized. There's almost an equal number of male and female employees, and the grants portfolio has grown to over $20,000 million. So I think that's plenty to celebrate. So just like Professor Kirenga said already, we welcome you to celebrate with us. He has mentioned the key culminating activities on the 27th and 28th of November. But until then, please keep joining us for this webinar series, one of which is today and a few more to come, as well as our community outreach activities. I think that's it. Over to you, Professor Kirenga.
Thank you, Damali. At this time, I invite Simon, chair of the celebrations, to make some few remarks, and we'll go into the presentation.
Prof, perhaps I come in after the presentation, if you don't mind. So far, so good in terms of communicating to the audience. I can come back and just wrap up a few things on the celebrations, if that's okay.
Okay. Wonderful. So our members join me in welcoming our presenter for today, Dr. Winters. Winters, take off time to introduce yourself at the beginning of the presentation. But members, in brief, Dr. Winters is a research scientist at the Lung Institute, and he's a medical doctor with training in public health, and recently completed a PhD from the University of St. Andrews in a topic related to epidemics. Maybe Winters will say about this a little more. He's one of the high flyers at the Lung Institute, and recently his main focus is to lead the new formation, which you are seeing on my chart here, called ICER, but also many other projects that he supports. Winters, you are welcome.
All right, thank you, Prof. Kirenga. I hope I'm being heard. Of course, it's an honor to be introduced by you, Professor Kirenga, the founder, or one of the founders of the Lung Institute. As mentioned, Winters Muttamba is my name. And I think it's a privilege for me to be delivering this talk today. If I was newly wedded, they would say I'm in my honeymoon. A couple of weeks ago, I got my PhD from the University of St. Andrews. And still, like he mentioned, it was related to epidemics, COVID-19 to be specific. So I'm talking about something I'm very passionate about. And I've seen this from since I joined the Lung Institute, not 10 years ago, but probably something close to that. So for this afternoon, I'll be talking about or taking you through a journey of what the Lung Institute has been able to do over the last 10 years. Of course, I thought when I was asked to talk, I thought I would keep away from the scientific things to do with the odds ratios, p-values, but I'll try and limit them because I want to just tell you a story of what the Lung Institute has been up to. This is how my talk is organized. So I will quickly introduce epidemics. I will take you through what MLI has been able to do. I've listed only 3 for now, and I will tell you why. I will document or take you through some of the lessons that we've learned over the 10 years that we've been dealing with epidemics. And then pick out some of the things that I feel should be part of our priorities in the next decade. I think it's important that I first break this thing down, epidemics. And most often there is a temptation to confuse epidemics with outbreaks. So an outbreak is a sudden increase in the occurrence of a disease in a localized area. And there are some key terms here: sudden increase and then localized area. Whereas an epidemic is a more extensive outbreak. That's how you'd put it. It's not really localized. It goes beyond confines and affects many people at once and spreads rapidly. It's often sudden and leads to an escalation of cases. Then what is a pandemic? A pandemic, you would say, is an epidemic that spreads over a bigger geographical area. It could be an entire nation, or it could be the world, and most often affects a large number of people. Most of the pandemics that we know have been actually caused by viruses. Most times, these are new viruses. And because of that significant increase in the number of cases in a very short time, the thinking is that by that time, many people do not have immunity. So it's normally the new viruses that come in and cause all this havoc. Pandemics normally result in social disruption and or economic loss. I think COVID-19 is the most recent example that we can all relate with. Some bit of history. We've been, this topic of pandemics, epidemics, outbreaks is not a new thing. And when I did the search online, I noted that there have been 249 pandemics recorded in history from 1200 BC. And this is up to 2019. Probably the number might even have gone up. Now, I mentioned the pandemics have been 249, but like I said, normally it starts as an outbreak, gets into an epidemic, and before you know it, becomes a pandemic. And probably I will save you this picture, but what this picture is basically showing you, now I need to know how to put, okay. I'm trying to navigate your pointer. Okay, that in the 19th century alone, we've seen many outbreaks of pandemics or epidemics. Most of them have been due to cholera, but the ones that have been caused by the viruses as we know them are largely, I think I need to pick out the Spanish flu of, that should be 1918, that went up to 1920, which killed probably between 50 to 100 people in Europe and the US. And then here in, this should be orange, the HIV pandemic also is in here, killed up to 41 people. And then the one that we all relate with, or we can really relate with, is the COVID-19. Of course, most of us might think that this was probably one of the biggest, but no, like I've mentioned, there have been others before. COVID-19 resulted into up to around 27 to 30 million deaths So it's quite a big one that has happened in our lives as well. Now in Africa, and I bring this out to mention that epidemics, pandemics, outbreaks are with us. They will not go anywhere. The best thing we can do is to see how we respond or how we get ready to respond when they do happen. So I picked this from the World Health Organization, which releases weekly bulletins on outbreaks and other emergencies. So they keep a note of all those events of public health potential. And you note that we have up to 104 ongoing events. And these are so many, even your famous Mpox is in here. So they're up to 104, and you see this map is quite decorated. It's like each and every part of this continent actually has something happening. So that again goes on to underscore the bit about epidemics being around us, and this will keep being around us even for the unforeseeable future. 40 of these are grade 3 events. That's quite advanced. 16 are grade 2. I think grade 0 is, this is what, grade 1 is 0. But also I wanted to bring out, and I will come to this, 19 humanitarian crises happening right now on the African continent. And this again creates a very suitable environment for these outbreaks. And I will come to this in the next slides. Now, these guys, Amanda and colleagues, reviewed the outbreaks or pandemics or epidemics from around 1970s or thereabout up to 2019. And what they discovered is that actually there have been a lot of spillover events. Now, these are events that start in the wildlife or animals and finally get into the humans. So you can see a 4.9 or actually 5% increment from around 1970 to 2019. And why are we seeing this happen is what I'm trying to explain here. One, I will pick up on the previous slide, the humanitarian crises that are happening, mass people movements because of instability leading to refugee crisis. But also we see, and this is what actually we know, that most of these outbreaks have actually been caused by human activity. And some of this human activity includes increased trade in animals, increased demand for food, the farming practices, technology, but also over the last couple of years, we see closer interactions between the animal, the wildlife, and the humans. And this is because of the many activities that are happening. We see encroachment on the forestries, on the forests because of need for land. We see, of course, deforestation. We see increased travel. The world is increasingly becoming connected. So an outbreak here could potentially spill into a pandemic elsewhere. So some of these things have actually led to what we are seeing here, a 5.5 increase in the occurrence of spillover events. Now, with this increase, you'd expect that the African continent is actually trying to do everything possible to be better prepared. And I picked this slide from works done by Chinwe Iwu Jaja. I think Jaja is easier to use. This is someone from Nigeria, but I think one of the other authors is probably someone we know, Dudu Zero, someone from South Africa who I happen to have worked with. But they did a bibliometric analysis of studies that are being done around vaccines. And these were mainly vaccine research, vaccine trials, and vaccine reviews. Now, I want you to pick interest in the vaccine trials, which is supposed to bring onto the market medical countermeasures to respond to that increased number of events. And what we noticed, or what they noticed, that from 2016 to around 2024, there's been a decline in the number of vaccine trials on the African continent, 6.1%. Whereas we should be increasing, this is going down. But there is a slide I should have put here. Even with this decrease, majority of the trials being done on this continent are actually in a certain part of Africa. Most of them are coming from the southern part of Africa. Most of these trials that we are talking about, majority are being done by South African investigators or scientists. Now, the topic for today, how did MLI get into this space of epidemics? And of course, from 2015, I think MLI has been this, especially if you look at TB as one of those epidemics. Of course, majority of us still think TB is an epidemic, but for today, I'm going to keep away from TB because I know there will be another presenter who will probably talk about TB. So I will talk about the other three, but how do we get in here? I think most of us probably know our role in epidemics because of COVID-19. And I think in 2019 is when we really decided to go all guns blazing, for lack of a better statement, into epidemics. And I bring these pictures here. I decided tactfully looked for pictures where we have the army. Because if you read about epidemics and the army, since time immemorial, the army has been on the front line. So they are not only on the front line for security, but also for protection of people's lives when it comes to health. And this slide is also packed with another message, the role of collaborations in responding to some of these epidemics. And MLI has been fronting this, and as I go through the subsequent slides, you'll actually see that we've not done this alone, but rather through leveraging the collaborators that we have, the institutions and the scientists. Now we'll start with some of the earlier works that we did on COVID-19, and this was largely around epidemiology. So while people were struggling with COVID-19 in Europe, in the US, no one really knew a typical COVID-19 patient in this part of the world. We knew, for example, in the global north, you had to be elderly, you had to have a comorbidity, and most times, actually, you had to be symptomatic. So with the group here at the Lung Institute, we're the first group to actually characterize the COVID-19 patients in this part of the world. And this is one of the highly referenced papers, characteristics and outcomes of admitted patients infected with SARS-CoV-2 in Uganda. So here we characterize the first 56 participants. And what we noted that the trajectory of disease was very different from what was being reported in the global north. Our patients were actually young, and they were mainly or largely asymptomatic. Through this same work, we are among the first group that actually started giving some pointers on whether hydroxychloroquine works or not. You know, there was word from elsewhere that actually HCQ or hydroxychloroquine could actually be repurposed. And many people started running to pharmacies to buy this. But we actually found out that HCQ did not improve the COVID-19 treatment outcomes. And of course, the subsequent work built on that, including the trial on HCQ that was done. Now, we had trouble with treating COVID-19 patients. Most of the treatment was actually supportive. There are some of us who thought probably we could go the natural way. There was wide mass use of herbal remedies. And for us as a group, and I should have mentioned this, that when COVID-19 emerged, we quickly assembled a group of scientists and we started working under what we call the Epidemics Research Group at the Lung Institute. So we started scratching our heads on how best can we manage the patients that we're seeing. And we went into something that had been used previously. Most of us might know that convalescent plasma has been used previously for some other diseases. So we thought that if someone had COVID-19 and they recovered, the reason they probably recovered is because they mounted a good immune response to fight the virus. And because of that, the assumption was that they have high antibody titers that we could harvest in plasma and probably give them to patients who have COVID and then see if they could actually have better treatment outcomes. So we did this work where we went around the country and identified the survivors, collected the blood, processed the plasma, and administered. And the picture there, for me, is a picture that I think I will always use, because that is the very first participant who received the COVID-19 convalescent plasma. Now, I need to mention that this had never been done on this continent. But of course, we were a bit taken back. We all thought, yeah, COVID-19 convalescent plasma could work. But in terms of the main outcome or the primary outcome of viral clearance, we did not see that signal in terms of COVID-19 convalescent plasma leading to faster viral clearance. And this Kaplan-Meier curve is basically trying to tell you that there was no benefit in terms of virological clinical improvement, including even time of hospitalization or the hospitalization period, or ability to move from mild to moderate and moderate to severe. So this is one of the first attempts we did in trying to find out the best way to manage our participants. And I think Professor Bruce Kirenga must be one of these guys. Now, you know, during COVID, it was very hard to tell who is who, but I would suspect he's someone, not this one, because I think this one has a different name, but probably one of these. So that's one of the trials that we did, and that paper was published and it's available. Again, trying to find out the best way to treat our patients, we got into a network that we called the TICO network, or Therapeutics for Inpatients with COVID-19. This was a multi-country network that was doing trials on very many monoclonal antibodies, because the thinking was that these monoclonal antibodies could actually be used to treat these COVID-19 patients. So we got involved in two of these. The first one, now this one is very hard, but that is the word of the monoclonal antibody. And the second one is what they call the ENSO-VBEP. All these are monoclonal agents. So we again use these products in patients or COVID-19 patients who are hospitalized, but still we did not see better treatment outcomes in participants who are receiving these products. Actually, for the second one, the trial had to be halted for lack of fertility. And there are a lot of publication on this work that is available online. Then we started going back to the drugs we have. Now we could involve new ones. And one of the drugs we looked at is fluvoxamine, which is used by psychiatrists. I think that's an antidepressant. So we thought we could repurpose fluvoxamine, so we quickly developed a trial where we used this fluvoxamine to see if it would, for example, reduce the mortality. It could lead to faster symptom resolution among inpatients with COVID, reduce the hospitalization period, and of course, symptom resolution. And enrolled 316 patients and gave them 100 milligrams of fluvoxamine twice daily for up to 10 days. And what we found was that fluvoxamine was significantly associated with reduced mortality, and it led to a faster symptom resolution. I think this was again a trial that was quickly taken up in terms of influencing policy. And there is a paper for that as well. Now, around that time when we were struggling with antibiotics, with therapeutics, vaccines started emerging. And many people had issues with the way these vaccines came on the market. The process was quite swift or fast, that people started thinking that maybe these things don't work. So what we did, again, we wanted to evaluate them. So what we did, we evaluated the impact of one of those vaccines, the Chadox or the AstraZeneca, on COVID-19 treatment outcomes. And we enrolled up to 1,500 participants across 2 large COVID-19 treatment units. One of them was Mulago National Referral, and then the COVID-19 treatment unit at Nambole at that time. And what we discovered is that actually vaccinated participants or vaccinated patients were protected from dying by up to 55%. And among those who are already vaccinated, the guys who had gotten 2 doses of the vaccine, we did not notice or report any death. And even those who had received just 1 vaccine, mortality was much lower than those who had not been vaccinated at all. And we pushed out this policy brief. Because at that time we were working with Makerere University with that funding, we pushed this out. And this is something the ministry clearly took on. Then we started asking ourselves, these vaccines from clinical trials have actually been doing a good job, but how would they do or how would they perform in a real world setting? So we wanted to know the performance or effectiveness of these vaccines. So we undertook 2 studies. One of them is what we call COVEP, the COVID-19 Vaccines Evaluation Program. With funding from China CDC, we set up to around 10 sites across this country. Some of them were sites that were involved in the national influenza surveillance, but others are sites that we opened up and then performed or undertook or implemented a study which used the test negative design, where everyone who reports to any of these facilities with signs and symptoms of COVID-19 and wants to access a test and turns negative would become the control. The guys who turn positive would be the cases. And then the other group of participants who are interested in are those that were presenting at any of these sites with severe acute respiratory infection, and then would test them. Now this, for this study, data analysis is going, but there are a few pointers to the performance of these vaccines. I think at an opportune time when we are done with the analysis, we should be able to present those results. Now, the other work we did, funded by the government of Uganda, is to assess the feasibility, acceptability, and hesitancy of COVID-19 vaccination in children 12 to 17 years. At that time, the ministry was rolling out the Pfizer. And we moved around the Kampala metropolitan area, and I think the PI for this is here, Dr. Nantanda. So we moved around the Kampala metropolitan area and conducted a mixed method study where we had interactions with parents or caregivers of children, and wanted largely to find out if they would be willing to allow their children to get a COVID-19 vaccine. And we found that actually the COVID-19 vaccine hesitancy was up to 25%. So a quarter of our respondents said no, would never have our child vaccinated. And there are reasons they were giving. Some of them included, we fear the vaccines. There are those whose children had gotten adverse events following immunization for the previous vaccines that are part of the national programs. So they were a bit hesitant to have a vaccine. There were myths and misconceptions. This is a Muzungu thing, you know. And then, of course, there are those who thought that COVID-19 is not a big issue in children after all. Why should we vaccinate them? And that report is available as well. Now, I quickly want to talk about this that I sneaked in, the CONAT program. Again, speaking to the bit about having no therapeutics for some of these epidemics when they emerge. So we have developed a program that we call the Clinical Trials of Natural Therapeutics Program, fully funded by the government of Uganda and run at the Makerere University Lung Institute, of course with partners in the country as well. And one of the things we are trying to do is to see, can we harness the natural therapeutics that we have in abundance here to be able to deal with some of the common illnesses that we are struggling with. Now I bring in this slide because one of the trials that we finally concluded and analyzed was actually responding some of the acute viral respiratory illnesses, including the SARS-CoV-2, which was responsible for COVID-19. So we wanted to see if we gave you this product, in addition to the standard of care, would your symptoms clear faster? And what we've been able to note is that actually these products lead to a faster clearance of symptoms. And most times that's what disturbs the patients, the symptoms. And this chem curve basically shows you that these are two products we're evaluating against the standard of care for acute viral respiratory illnesses. Now, most of us will know that the standard of care in Uganda for acute viral respiratory illnesses is actually supportive treatment. But you will see that where we gave you supportive treatment, in addition to the product, the participants were actually having their symptoms resolve faster. If you see this red for standard of care, it's dragging or falling below the other two curves for the two products. And for us, that was quite a good signal. And we think we can build on this, probably start thinking of therapeutics for mpox that we are struggling with, and I will come to that as well. Now, while we're thinking now COVID-19 is an ongoing issue, most of us had not rested. We thought now we're going to take some vacations when Ebola struck. And this Ebola struck at a time when we were all recovering from COVID-19. The 6th AVD outbreak that came out in around September 2022, because of the work that I've just gone through that MLI had done, the World Health Organization and the Ministry of Health engaged MLI, appointed MLI to lead a vaccines trial. And this was a vaccine trial to evaluate the candidate vaccines against the strain of Ebola that we're dealing with at that time. However, I need to report that we actually couldn't proceed with the trial because the outbreak or the epidemic was declared over. So it looked like the outbreak was ahead of us in a way, or the epidemic was ahead of us in a way. But we picked one very important lesson that we'll hold on to for probably the many years to come, that preparedness is very key when you're dealing with epidemics. Then in 2025, we had all come back from, I think, our Christmas breaks. Ebola struck again. And now, this is where you start thinking preparedness is very key. Remember the last slide. So we quickly, again, mobilized to be able to respond. This time we are like, no, this time we have to be ahead of the outbreak or the epidemic. So we went back and recalled a protocol that we had wrote in 2022 that we had kept as a living protocol. And this protocol was to evaluate the efficacy and clinical safety of a Sudan Ebola virus vaccine. Now, while we're implementing this, other questions kept emerging, so we amended it to assess the immunogenicity of this same vaccine. If we gave you the vaccine, how would your body react in terms of building an immunological profile that would fight off the disease. This outbreak, of course, came at a time when we had seen the cats. You said cats, you know, the US cats and all that. So we quickly deployed and evaluated one of the candidate vaccines that we had at that time. A candidate vaccine that uses probably similar structure that one of the vaccines against the Zaire Ebola virus strain uses. So we thought if we deploy the same, probably this might work. And these are the questions we are still trying to answer. So this IP, the investigational product, uses a recombinant vesicular stomatitis virus technology, or VSV, that was used to produce a VEBO for the Ebola Zaire vaccine. So what basically they did is you remove the glycoprotein for Ebola Zaire and bring the glycoprotein for Sudan. And I like using the analogy of a car. The car sits on a frame, you have 4 tires, rim 16 Pirelli. Now you remove the Pirelli and bring and put the Linglong. You expect that the car will still take you to Jinja. The same way the Pirelli will take you to Jinja. That's the assumption we have. So we've been evaluating this candidate vaccine in that Ebola trial. I need to mention that we called it the Tokomeze Ebola trial. But when the WHO approached us, the name they gave us was Solidarity Against Ebola. And we thought we needed to localize this protocol, give it a local name. And that's how we came up with Tokomeza. This is a Swahili word, kick Ebola. Now, one of the things I remember when we were trying to get a name, everyone was putting the other to their end. Whereas I wanted the Chinyankore name, there are people who wanted the Chiganda name, the Chigisu name. So we thought maybe Tokomeza, which is Swahili, might be all encompassing. So that's how we came up with the Tokomeza Ebola trial name. Now, looking at the immunogenicity, I want to quickly run through this. I know we have lab people online. We want to determine the immunogenicity of the Ebola Sudan vaccine candidate that we are currently giving. And we also want to determine how long does this immunogenicity profile last. If we give you this vaccine and you develop, say, the antibodies against this vaccine, how long would they last? And to the left, I picked these. Now, this is something we want to reproduce. These curves are for the VEBO that I mentioned, which is used for the Zaire strain. And what they did here is give participants the vaccine, the Zaire Ebola vaccine, and then follow them up to 365 days. I'm also struggling to actually read these. I'm using the big screen, which is quite far. But and what they discovered is that by the 28th day, you have the IgG antibody profile or titers shooting, and then later they drop, but then they keep a bit sustained up to day 365. And for us, that is very good. If we gave you the vaccine now, say for the Zaire Ebola virus, you'd be protected up to even more than 1 year. Now, remember the period we have between the 2020 and 2025 epidemic that we had. That's like how many years? 2.5? So we think if we find that actually this vaccine that we are studying is very potent, it could potentially protect individuals in the high-risk areas for more than even 2 years. The other question we want to answer, yes, we have these sufficient antibody titers, but do they do that they should do? Or they are just bogus titers? So that brings in the bit about the neutralization. And what these guys showed is that actually, even by day, I think 28, these antibodies are still able to do what they are supposed to do. Then you see a drop, I think up to, this is 56 or something, And then you see now that ability going up. And people are wondering, why does it drop and finally go up? And people think there is immunological maturity happening around that time. So we want to replicate this for the candidate vaccine that we are currently using. Maybe the curves will be the same, or maybe they will be different. We'll probably come back later and give you some answers. This is the trial that I mentioned. Again, speaking to readiness, this is a trial that we're able to conduct or implement within 4 days of an outbreak being announced. Of course, there are some of us who still think it is 3 days. The fourth day, I don't think was complete. So there are people who think it was 3 days, but regardless, we think that because of the preparedness, we're able to quickly swing into action and implement this trial. So epidemics and preparedness should go hand in hand. And preliminary data analysis is ongoing, but what I need to mention is that actually the DSMB has sat many times and allowed us to proceed. And you know what that means. Now, while we're struggling with all these, there was something happening in our neighborhood, in the DRC, Mpox, monkeypox, that people know it as. So we started dealing with an old disease, very old. It had been endemic in most of Central and West Africa. Just a bit of history. I think the first human case was diagnosed in Congo in 1970. Not that we had not picked it earlier, but had been picked earlier, I think in Denmark, in monkeys, and probably that's where it gets the name. But now, in our neighborhood, these cases were going up. But also take you back, in 2022, the world witnessed an epidemic or a pandemic of Mpox in areas where it had never been reported. And this is mainly in Europe or global north. And what we know for a fact is that this was largely driven by, this is MSM. What is MSM? Men having sex with men. Eh? The transmission was in this group, okay? And was being driven by clade 2B. Maybe clade, I don't know how to make that one easier for people to understand. A certain type, okay, family that they call clade 2B of this Mpox virus. Now, at the end of 2023, the cases in DRC started going up. Now, DRC is actually very close here. So when something is happening in the neighborhood, you just know it's a matter of time, especially in a region that is highly porous, with some bit of instability, but also a lot of movement across the borders. And I saw Professor Katoto here online. Now, with our colleagues in DRC, we quickly swung into action and wanted to really understand this Mpox. Why is it acting differently from the one that we saw in 2022 affecting the north? And we quickly pushed out this commentary in the Lancet, where we documented the shifting transmission patterns of human Mpox in South Kivu, DR Congo. Now, I need to tell you, colleagues, that this is one of the highly referenced papers. Of course, until recently, there were not many references on the epidemic that was happening in Congo at that time. So we quickly pushed this out, working with our colleagues in DRC. I mentioned Professor Katoto, who is a very good collaborator of ours. And around the same time, we started thinking of vaccines that we could deploy to handle the surge in cases. And the MVABN, or the modified Vaccinia Bavaria Nordic vaccine that had been used in the 2022 epidemic in the global north, was deployed and found to actually work. That time, So we thought we'd do the same in DRC and Uganda. Again, that goes to show the power of collaboration. So working with Professor Katoto from the university, the Catholic University of Bukavu, we implemented this trial. We so far recruited 1,560 participants. But we want to understand if we give participants who have been exposed to mpox, will they be prevented from getting mpox? That is the first question. And the second question is, okay, they might end up getting mpox, but what kind of disease do they get? Is it the severe form, the mild, or they will be asymptomatic? And I need to note that the sample size has been realized, analysis was ongoing, but we already started seeing some safety signals. Now I put these pictures here, again, to show you that as Africans, we should not wait for our friends from the global north to come before we do anything, you know? And I mentioned the power of collaboration. So you will see Professor Kirenga here. This should be Dr. Misaki. I think this is Professor Katoto, Dr. Misaki. They had to quickly run to Bukavu. I think some of them had probably were going there for the first time and see how they can work collaboratively with the team there to handle a common, you'd call it a common what? Threat. Okay? So that underscores the power of South to South collaborations when you're dealing with epidemics. Then we won some funding from EDCTP and tried to answer some questions that we're seeing. So one of the things were like when you get an infection, you could survive or you could die. You'll die because your immune response is ineffective. You could survive, but even after surviving, you still have some viral persistence. Or the immune system is so nice that it clears the virus and then you heal completely. And then the guys with chronic infection, as their immune response finally goes down, they could be symptomatic or asymptomatic and ultimately die. So we were asking ourselves, what happens at each of these stages? Why is it that some individuals will quickly move to death and other individuals will probably clear or maybe have a symptomatic disease? So our questions, we think, can be answered through this Decipher Mpox project. Decipher is actually an English word. People went to nice schools. Decipher. Better understanding, okay? Better understanding. So we think there are host genetic factors that probably influence what we see here. And what are we going to do? We'll enroll 108 participants, 36 cases. So every participant we get and qualifies, we follow them up and ask them to link us up with their parents. Okay, so we are looking at parental pairs. Now there are those who might not have parents anyway. So we say, link us up to your first degree siblings. And so far, this is a project that is happening. Enrollment is happening in DRC with some activities happening here. Then Mpox. Most of us who have read about this Mpox, the pregnant women are actually among the risk groups. And in both Uganda and I think in DRC, we see a lot of cases among pregnant women. So we want to understand what's the impact of this infection in pregnancy in terms of the outcomes and the immune response. And we are building up a cohort of pregnant mothers in the DRC. So far enrolled, I think 242. Some of them are controls, others are cases. But one of the things we are seeing is that actually Mpox is quite brutal when it comes to pregnancy. We so far have seen adverse outcomes, spontaneous abortions, preterm births, neonatal death, intra and interpartum bleeding because of what? Mpox. So these adverse outcomes are more pronounced in the cases as opposed to the controls. And that work is ongoing. But one of the other things we are doing is harvesting the placenta and trying to understand the histopathological features That again is going to be done under this plague mpox. Collaboration with our partners in Bukavu. Again, Professor Katoto is here. Our partners in Belgium and I think the other countries need to recall, but this is a partnership. Then the Mpox Africa or Mpox Vax Africa. Now, one of the things we've seen again is things we think will work in the global north actually don't work here. Africa is a very genetically diverse continent. So we think, whereas this vaccine was actually found to work in the global north, it might not work here. So what are we doing? We've gotten a protocol, a trial that was done in Europe, and now we want to replicate it here and see if the immunological, with the immunogenicity that was realized with that vaccine is what we'll see here. And what we are doing is we are following up high-risk individuals who've received the MVA, only the Mpox vaccine, collecting their blood for a period of 1 year, and we try and see the immunogenicity following vaccination. Do they generate enough antibodies? If they do, how long do these antibodies last? Should we be able to have antibodies up to 1 year, or within a week, everything is done? But even then, these antibodies that they have been able to mount, are they able to do that we are supposed to, or they are supposed to do? So we are looking at the neutralization ability of these antibodies. So we are recruiting, or we've recruited 330 participants in Uganda and in the DRC, and we are following them up, collecting blood for those immunogenicity assays. Mpox, currently there is no proven therapeutic for Mpox. So we are thinking we should start looking for potential therapeutic for Mpox. And one of the efforts we've started is what we call the MOSA trial, which is an adaptive platform trial that is evaluating various antiviral therapeutics for Mpox. This is very key for our setting. Most of us might know the story of tecovirimat, an antiviral which was doing very well, again, in the global north. We brought it to Congo. I don't know what the right word to use in terms of ability to stop the infections, but also, no, not to stop the infections, to lead to better treatment outcomes. Whereas it was safe, it was not able to demonstrate that it can actually lead to better treatment outcomes. And that's why we need to evaluate these therapeutics here. And one of the therapeutics that we are looking at right now is an antiviral called brinsdorfovir, or BCV. This is going to be evaluated in patients who have Mpox in Uganda, DRC, and many other countries. And we are looking at 422. The approval process for Uganda is ongoing. Hopefully next month, we should be able to start the recruitment process. How about the diagnostics for Mpox? And I'm about to get done. Diagnosing Mpox is challenging. I know we have the PCR, which is the gold standard, but it's not readily available. Actually, up to 40% of the cases who should be getting an RT-PCR do not get. And that again is very concerning. So what we are saying is we should actually start looking at the lateral flow devices, or the RDTs. So we are currently evaluating 2 RDTs. One of them is the NG test, and an RDT, or lateral flow device, and the other one is the Dragonfly point of care molecular diagnostic. For the NG test, we finished the work. The data has been analyzed. Data was collected from Uganda and the DRC up to, I think, around 500 participants. And I just want to give you a quick peek of what we've seen. In terms of agreement of the results, when you use the PCR as the gold standard, we see up to 82% in Uganda and 78% in DRC, agreeing, the agreement in terms of positivity, a positive RDT and a positive PCR. And for the negatives, you see again 83, 92, not very bad. for an RDT. And then among the discordance, 14, 18, 43, 8. You can say this is a bit quite a good result for an RDT. In terms of sensitivity and specificity, overall sensitivity is 70%, keeps dropping in infants. Again, what we see for almost all diagnostics, at least for TB that have worked in, you tend to see poor performance of some of these diagnostics in the children, specificity 90, PPV 92, NPV 60. So what do these results mean? That actually the RDT, the NG test, would actually be used as a triage in people who really need a PCR test, okay? And should be used as a rule-in rather than a rule-out. What do I mean? Is if they tell you this is a positive, most likely it is a positive. But the guys who they say is negative, don't stop there. Probably you need to bring in the PCR as well. And of course, the discussions are ongoing at continental level on how we could probably use these results to inform policy. I need to mention that the sensitivity of 70 is actually below the WHO target product profile of 95. But we are challenging that because that profile is based on when you're diagnosing or evaluating using lab samples. You sit in a lab, there are samples of mpox, then you start evaluating. But this was a field evaluation study. So that's why we are challenging, and hopefully this good result influences policy. In terms of capacity building, we've done all this, but it is very important that we build capacity. You remember what I said, epidemics need to find us prepared. So we have started doing that. The clinical trials ward that we have up there, still very small, but we can still do much. The vaccine cold chain capacity. Some of these investigational products need to be kept under certain temperatures. Otherwise, you mess up the integrity. So we've established a vaccine cold chain facility, the one you see here, with, these are called Arctex. I had to learn this. Arctex are like moving refrigerators. They're able to take a vaccine from one end of this country to the other and keep it very well for a period of up to 3 to 5 days. So we have all this, that facility is well established, but we are thinking that probably we need to move into probably bigger space, and I will not talk about this, but that's what we are thinking, that you would probably need a bigger clinical trials ward, you would need a bigger vaccine a cold chain facility. Capacity for students or building human resource capacity is also very critical, and we've started this again within the projects that we are doing. These are 2 PhD students. Of course, there are many. Even me, I should have been here, okay? But I've put the latest ones, But most of us should be here because we benefited from some of this work. I told you my work was on COVID. So we brought on board 2 PhD students, Claudine Mukashaka, who is looking at the biology of the B cells immunity in mpox survivors in Uganda and the DRC. And here is Hatum from the DRC, who is looking at genetics and immunologic factors influencing what we see in terms of clinical outcomes when someone gets mpox. And I know that the supervisors of these students are here. I think Professor Katoto is one of them. And of course, there are many other things. Now, the other thing that I like talking about is ICER, and Professor Kirenga mentioned it, the Epidemics Research Coordination. Now, colleagues, the Lung Institute will not do this alone. If you notice, for most of the projects I've been saying, we work with so and so, we work with so and so. So we've tried to bring all these institutions and scientists under one umbrella to have a more coordinated effort. And that's how we've come up with the Epidemics Research Interdisciplinary Consortium for Epidemics Research. Now this, again, and we need to appreciate the Ministry of Health, they noted that actually, this is something we started around 2022, that there were many questions around the Sudan Ebola virus epidemic at that time that needed to be answered. And they challenged all the scientists and institutions to start providing answers to some of these questions. And when we start, we actually discovered these questions were interdisciplinary in nature. You needed all kinds of people and all kinds of institutions. And that's how this got developed. Now, while we're trying to do that, mpox emerged. And then we discovered that actually the questions that we're grappling with the Ebola virus or Ebola epidemic were similar questions that we needed to answer under mpox. And that's how we became now a regionalized kind of consortium. Originally started as a Ugandan consortium, but now a regional consortium. And the main goal is to foster interdisciplinary research collaboration to enable rapid infectious disease epidemic detection, containment, and optimize clinical care delivery to inform policies and improve health outcomes. So that's ICER. And I've just picked a few of the scientists that we're working with, both in Uganda and outside Uganda. This is how ICER is spread. This is an old map. I need to update it. We have more shaded areas here in Africa. We have our colleagues in Europe, Northern Ireland, Scotland, Myanmar, St. Andrews. We have the US, those who did geography. What is this? US, eh? Yeah. Yes. Okay, so these are the scientists we are working with. You can see some familiar faces, but like I said, we need to expand this because there are many more scientists that we are currently dealing with. And like I mentioned, it's an African-led consortium with representation in several African countries, and we are leveraging our long-standing collaborations from Global North partners. Most of the projects that I've gone through actually have collaborators from the Global North. What have we learned quickly? That for epidemics, it's not business as usual. You have to be prepared. There are many ethical issues you need to navigate. For example, for the last outbreak of Ebola, you're dealing with an emotionally charged group of potential participants. But then how do you make sure that you keep an eye on the ethical issues? Community engagement is key, and there is need to build long-standing collaborative relationships with these communities. You don't need to wait when the epidemic happens and then you want to engage them. Start the process early. The window of opportunity is normally too small. Of course, for COVID, we had all these many years. But you can see for Ebola, you know, for each outbreak, actually, we take a shorter time because probably we are getting better at the game. But how do we use that window of opportunity, that small opportunity, to be able to push the science? And I think that, again, goes to underscore the role of preparedness. Well-annotated biospecimens are key. You can't answer all the questions in just 1-2 months. So what do? Pick as many samples as you can, and then be able to answer some of the questions that might emerge, because you might not have a chance to access the participants in an outbreak. Then you need to plug into the national response. Most of these projects we are doing, we're actually working collaboratively with the ministries. Let it be here, DRC, TZ, we plug this research response within the national response. And a clear example is what we did during the last Ebola outbreak, where we are working collaboratively with the surveillance systems, for example. We need to leverage the South-to-South collaborations. For me, I think this is one of the biggest lessons. When we started the Ebola vaccines trial, we were able to call on our colleagues from West Africa because they had lived this, they had gone through this. And I can tell you, they were able to support us. For the Ebola, for the mpox studies that we are doing, the collaboration that we have with our colleagues in Bukavu has also been very, very helpful. So we need to leverage the South-to-South collaborations. Can we start thinking of new methods of evaluating medical countermeasures? Like I mentioned, the window of opportunity to answer all the questions is very short. So we need to start thinking of better strategies to answer some of the questions. And one of those approaches that is coming is the immunobridging. Probably I will not go into that, but that's something we need to think of. Preparedness. We need to be very ready in terms of having personnel, the capacity, The pre-approved protocols, I told you we were able to start the trial in 4 days because we had a protocol from 2022 that we kept as a living protocol. So we need to make sure we are prepared at any one time. And we've documented this. That paper is available on how you could use an epidemic, okay, to build capacity so that when the next epidemic happens, you're better prepared. Where do we go from here? Quickly, I will go through those. I'm thinking, and remember, I was supposed to talk about the priorities for the next decade. For me, these are, I think, are priorities for the Lung Institute, but also for ICER, Interdisciplinary Consortium for Epidemics Research. Can we start thinking of human challenge studies, what we've called CHIMS, where we deliberately expose participants to a pathogen and be able to study the pathophysiology, okay? We expose you to COVID, and then we study you. How do you react? But of course, we need people who are healthy. We don't want to give you COVID and the next day you know what I mean. So for us to do this, we need to put in place infrastructure and capacity for this. And some of this capacity is in form of the containment facilities. You know, we don't want these pathogens to leak. So we need to start thinking of that. And ICER is thinking critical about that as well. We actually tried this, but some of us might have attended the webinar that Professor Sabiti delivered. We've attempted this, and we are not going to give up until we do this. And we think these CHIMS actually could support drug vaccine discovery and also shorten the time we take to have the vaccines licensed. You know, you have to go through all these clinical trials, phase 3 and all that. But we are thinking with this, we should be able to cut that process shorter. And then we have these products on the market in a short time. How about early phase trials? Most of the things I've been telling you actually are late phase trials, phase 3, you know. But how about we start thinking of early phase, phase 1, phase 2? Is there anything that should stop us from doing this? No. You know, now we wait for people from the global north to bring trials here, phase 3, start. But we should be able to do the early phase trials, and we need to put in place capacity for that. Infrastructure, like I said there, the picture you see, but also the personnel. If I show you of what is happening on the continent, Africa contributes only 3% of the clinical trials happening on this continent. But even the 3%, the majority are late phase. So we now need to start thinking of early phase clinical trials. I like this slide, pathogen hunting. Can we start hunting for this pathogen? Yeah, we go and look for them. And there are people who have started by now. These are guys who go to areas where most of these outbreaks have been emerging and try and find out, are there other potential organisms that could actually result into epidemics? And the goal is to outspace that disease, be ahead of them. And I will tell you that through this work, a new strain of Ebola was actually discovered, the Bombari. You can read about it in Sierra Leone. There in the picture, I think they have hunted the animal, not the pathogen. But for us, we want the pathogen. So the pathogen is probably with this animal. So that's what I'm thinking. Probably we might not go to the bushes, but is there something we can do to find out where these the viruses are, or where these pathogens are? You know, once you have them, then you're able to prepare how best to respond to them in terms of developing the diagnostics, developing the vaccines, and developing the therapeutics. Harmonized research. I think this I've been saying it. This epidemics thing is big. I don't think the Lung Institute or ICER will handle it alone. So we need to see how we consolidate efforts and strength of each and every institution and research scientists. And for us as ICER and as the Lung Institute, we'll keep looking out for those collaborations that we can leverage to be able to respond to these epidemics. Again, that's a picture. Professor Katoto, Professor Kirenga, Professor Misaki, somewhere in Bukavu. Again, Collaborations, collaborations, collaborations. Opportunities, there are still opportunities for everyone online here and opportunities for us in the room. Opportunities for research. I already talked about opportunities for students, but the opportunities for research. And I mentioned well-annotated samples collected during some of these outbreaks. And the Lung Institute has been fronting this. We currently have COVID-19 samples, and many scientists are actually tapping into these. And these are real samples, by the way. I didn't put this picture just for what? Maridadi. I put it there for you to see that we actually have these samples. And if you have a very good topic, you could actually answer using some of these samples. Our colleagues at UVI, Dr. Serwanga, is using some of these samples to profile the antibody and cellular immune responses among patients who are hospitalized or patients who had severe disease. But also we have research databases. We've been collecting all this data. You know, the projects have gone through, and the others have not talked about. So for some of the students, again, this is something you could tap into. The students, the career researchers would approach us and see how. Of course, we want you to also develop yourself, but also develop us through publication and stuff like that. We don't want to give you these databases, get your thesis and you're gone. We would want you to publish this work. And I'm done. Thank you. I don't know if we still have Prof. Kirenga or Dr.
If he's gone, I could chip in. He kind of hinted that he might be off. I don't know if I'm audible.
Yeah, we can hear you loud and clear.
I'm here.
Okay, all right.
Simon. Thank you so much, Winters. We will have some discussions for a few minutes, but let me ask Simon to give some wrap-up remarks. All
right, Prof. Thank you for the opportunity once again. I think this has been a powerful delivery, Winters. Yeah, I think you really did us very well. So I want to thank you for today's presentation, and of course, thank Professor for the moderation. Members on the call, this webinar or educational session has been put together as part of the activities to mark 10 years of MLI's existence. And you would agree with me that from the epidemiological point of view, I think MLI has really put their best foot forward. So Winters, thanks, and of course, thanks to Prof for, as part of the founders of this institution, for creating impact. MLI was established in 2015, as Damali mentioned, and we have had impact at national and international levels across all parameters, really, from the whole sense of the word. And having been around for 10 years with this substantial impact as highlighted by Winters, I think it is now time to really take stock and celebrate the milestones thus far achieved. In the past 3 to 5 months, we've been conducting a couple of activities to celebrate the 10 years of MLI's existence. And we have several other activities lined up over the next 3 months. Our climax celebrations will be in the month of November. But before then, we are going to conduct radio shows, TV shows. I think in about 2 weeks' time, we shall have a bicycle ride within Kampala to highlight issues around air pollution. Some of the researchers have planned to develop podcasts and other educational materials. So there's a lot in the pipeline. I saw we had about 130 participants on the call, which is excellent. Thanks to the publicity team for the mobilization. I think this is super. I really think that they benefited from the session. So please keep coming and please keep spreading the word. MLI and lung health. Lung diseases are projected to be among the top leading causes of death in the next 2 to 3 decades. And MLI was actually fashioned to address this problem. As health professionals, one of our biggest mandates is really to prevent disease instead of focusing on curation. So for those on call and for those who might have missed this session, lung health is an interesting area. You could invest your career. As I said, in the next 2 to 3 decades, lung issues will be really top on the agenda in terms of health care delivery. So Winters, as he went towards the end of his presentation, he emphasized capacity building. So the future of the Lung Institute is really in young researchers and students who I assume were the majority on the call. So we invite you to come and join the Institute. Prof, our director, is very open to students. He normally encourages people to come in as research fellows. I'm also taking this opportunity to invite you to join the Institute as research fellows, but also on your calendars over the next couple of months, please take note of our upcoming call for abstracts. This should be in the next 1 or 2 weeks ahead of our science symposium sometime in November. So please be on the lookout and spread the word. We shall also be having a dinner. This was cited by Professor in his opening remarks. A dinner celebrating but also fundraising function to be officiated by the Right Honorable Minister, Prime Minister, or Minister for Science. And finally, I think this was also projected by Winters in one of his slides. The founders and the managers of the MLI Institute have now visualized a center for advanced lung health, advanced lung care. I'm not so sure, it might be the first in the region, by the way. I'm not so sure if we have such a center within the region, but that speaks to the visionary, to the vision of the management and the founding members of MLI. So we are looking at setting up a center for advanced lung care, and this will be one of the highlights to be, celebrated and marked in the MLI at 10 events. There will be a groundbreaking ceremony officiated by His Excellency, the President of Uganda. So a lot of exciting activities and exciting events lined up, but all in the spirit of reversing the trend of deteriorating lung health, mainly driven by, of course, issues like poor air quality and so on and so forth. So thank you for coming to today's session. And thanks to Dr. Winters for really giving a powerful delivery in today's session. And of course to Prof for putting aside these 3 hours to moderate the session. From my end as organizing chair, I'm grateful for the opportunity to give the remarks and of course for the attendance on the house. Over from my end, Prof. Thank you.
Okay, thank you so much, Simon, Chair of Organizing Committee. I now open up the presentation for comments. Definitely there are a couple of them. I can see 47 charts since we started. I don't know whether Winters will have access to them, but as we peruse through, I am happy to allow some voice comments. Let me first close the messages so I can see your hands. If you put up your hand, I will see it, but of course the number is a bit big. I may miss it. Anyone wants to make a comment?
Professor, maybe I can say something?
Yes, Moses, I think that is Ochan. Yes.
Yes.
Go ahead.
Yes, thank you so much, Winters, and thank you, the MLI family, for all this great work. I just have one area, like one of the speakers said, when this invitation came, I thought I was going to hear only about lung diseases and things around lung. I don't know whether some people were also expecting the same, and either they were excited or not to come and hear more about what is done in that area under the Makerere Lung Institute, which I think there is a lot that has been done on it already. It could have come through another presentation, but not in Winter's presentation, which I think I may be familiar with some. So, but looking at the trajectory or the area or the scope of work which Winters has presented, I don't know whether the name Makerere Lung Institute still represents the work that Winters has presented, accurately. It seems there is a mismatch a little bit, I don't know, between the name and the scope of work which has been shared by Winters. I don't know what Winters has as a comment to this. Would you want to do something to the name, or I don't know, something like that? Over to you, Prof.
Thank you for that comment. Winters, over to you. We can answer that one as other people look for their hands to go up.
Moses, Dr. Chan, I knew that would come from you. By the way, that's why I started with a slide somewhere. It was the army. When an epidemic comes, you don't say, for me, I was trained in VIP protection, not combat. You will quickly be deployed. But anyway, what am I saying here is I mentioned that actually we've been doing a lot of work on epidemics, especially for TB, especially if you think TB is an epidemic, which for me I think is. Now in 2019, 2020, COVID came. We all know it was largely a respiratory illness. Now, we built a lot of capacity along that. Before we knew it, Ebola came. Now, many of us will argue that Ebola is not a lung condition. It depends on how you look at it. But for me, as a medical doctor, I know you can affect any organ. You can go to any organ. That's what I think. But the work, like you rightly put it, does not really seem to be lung related if you want to look at it from a basic or more realistic or simplistic way. But it is all because of the track record we've established dealing with epidemics that affect primarily the lungs. And also you might have learned that along the way, we had another baby born of the ICER, the Disciplinary Consortium for Epidemics Research. And the Lung Institute, again, of course, is a key partner in that consortium. So the things that we feel might actually not be lung related, or the epidemics that we feel might not be lung related, could actually be handled by ICER. But on changing the name from Makerere Lung Institute to Makerere Epidemic Institute, I don't think we'll go that route. I don't even think Prof would allow that, or even the clinicians. There's a clinician next to me who said, no, you can't do that. But I think for me, that would be my response. I don't know if, Prof, you want to come in, because I know you are key and you are behind the birth of both ICER and the Lung Institute.
I think you've really explained it. After COVID-19, which we handled very well, by the way, I think you saw the impact of COVID-19 in places where experts were lacking. If you want to do a comparative analysis, it is available online. We handled it very well, providing critical care and critical advice for the response. We realized that epidemic response and research is a cross-cutting discipline. It doesn't matter which epidemic has come, which organ is affected. The same rules will apply on how you respond to an epidemic and how you can research it. And that's how we started by creating an epidemics research group within the institute to handle epidemics work. Following that, mainly the starting of ICER actually was not driven by having non-respiratory epidemics. It was driven by the large number of people who wanted to work with us in the area of epidemics, who are from diverse settings, some of them non-academic, Ministry of Health and others, the community. We said, let's create a home for them under ICER. It is my feeling that they are now a bit more comfortable. Of course, some of them even from competing universities. Of course, you know, universities now compete. In our time, it was one university. So now there are many, even from other universities. So to give them a home such that they can be able to ride on our success to advance epidemic response and research. I have to mention, Mizaki is not on the call. ICER is endorsed by the Ministry of Health to respond to epidemics and conduct research. So that's what we did. About the name, your answer is as good as mine. The Lung Institute is here. No one can touch it to add any other word. This is the lung only. So you cannot touch, you cannot put anything else. Of course, there are many people who have agitated, especially people not from Makerere. They want to change it to National Lung Institute. Those proposals are there. There are very strong proposals to change it to Uganda Lung Institute. Actually, there are some people who have refused. I will not mention their name. Big people in this country, for them, when they write to me, they write Uganda Lung Institute. Then I correct them. I say, actually, this is Makerere's Lung Institute. Then they write back, they still say Uganda Lung Institute. It doesn't matter, Makerere is Uganda. But this is Makerere's Institute, and it will continue like this for some time. But of course, if there was an executive order, it will change to Uganda Lung Institute. But until that order comes, as Makerere University, we are very proud of our brand and our capacity to nurture institutions like this. I don't know whether most of these institutes actually they originated within Makerere. I will not mention their name because people don't want to hear them. But most of these big institutes actually originated in Makerere. So as Makerere now, we think we need to keep our brand to the extent possible. But for people who probably are uncomfortable with the word Makerere, for good reasons, by the way, not bad reasons. If I'm an alumni of Gulu University, I don't want to be forced into Makerere because I'm from Gulu, for a fact. You get it? These universities and alumni, they're like tribe. If I'm a Mchiga, you cannot force me into be a Musoga. You will be infringing on my rights. Yeah? So if I'm from Gulu University, I'm from Bustema, if you try to make me Makerere, I feel bad. But I think the other thing also we are going to do, this is the last comment I'm making on this, is to expand our mentorship on how institutions can be started and grown, such that different universities, different regions could learn from us to start similar institutes instead of dissolving what we've done. And we are available for mentorship. Thank you. Moses, I hope that suffices.
Yes, thank you, Prof. That's okay.
Okay. We can have like one or two more comments. I cannot see hands. You could unmute and talk. Winters, have you found anything urgent in the chat?
Yeah, was that Willie's hand? I think Willie wanted to say something, but some of them are actually thankful messages But there's no message asking for my mobile money line, but that's just a joke. One of the questions is regarding issues around hesitancy. And they're asking won't this be a challenge soon for the research landscape in Uganda? This is from Tweva Zekareb. We actually are seeing that as a big issue, and most of this hesitancy is the hangover, for lack of a better statement, from the COVID-19 vaccination. And we know the challenges that most people had around the COVID-19 vaccines. One was the speed with which they came onto the market, but also they had not been tried in Africa. So what we are doing, and this is part of the work that we are fronting at the Institute and ICER, that we need to build long-lasting relationships with the community. Community engagement is very key, not just when there is an outbreak. We need to do it even before. And I will tell you that the work will be much, much easier. Some of the reasons some people don't want these vaccines are because you never consulted them, for example. And for the trials that we even submit, the journals these days even ask you, the community involved, at what stage were they involved? And for me, I think that's one thing that will help us fight the issues around hesitancy. What challenges has the Institute faced in the implementation of these epidemics? The challenges are many. Of course, hesitancy is one of them that you mentioned, but also you want to do things very fast. I talked about the window of opportunity. For Mpox and the COVID-19, we had that luxury of time, but most epidemics will not give you that luxury. So you need to do the right thing, but within a very short time. So how do you balance the two is normally the biggest concern, but we've tried, and I think we are doing that quite well. But you also know, like I told you, Ebola outbreak of January happened at a time when there were cuts. So there was reduced funding, and I didn't mention it here, but institutions which know what it means to provide support through research or research responsive responses will definitely be able to pump in. I hope you know what I mean. As an institution, you should be able to avail some funds to kickstart some of this work. Otherwise, if you wait for a funder seated in an air-conditioned office in Texas to send you money, you'll never start, and before you know it, the outbreak is done. I think that is most of them are really messages thanking the Institute for the work done. Though there was one, I've missed it, but it was around, I think, reinfection, relapses. Yeah, I've seen it. Any ongoing research to understand duration of Mpox natural immunity versus the vaccine. As part of the Mpox vax project that I mentioned that we are working on with our collaborators in TZ and DRC, we are developing a technology that should be able to identify the immunology, that's the right word, immunogenicity, because of the infection from the immunogenicity caused by the virus. So we should be able to answer that question. And any plans to understand questions around Mpox reinfection versus relapse among survivors, report back with positive results months after discharge or recovery. I think that's a potential question that we can quickly pick up. I know we have some of the ongoing studies that could answer that, especially the studies that we have that are building codes, but I think we could discuss this further. And this was from Christopher Wagovera. I think, thanks for those questions, Christopher. That would be it, Prof. There's another one. Willie. Willie wants to say something, I think.
Okay, please go ahead, Willie.
And then
it is this movement.
Willie, we have Ignatius here as well.
Thank you very much, Dr. Winters and everyone following. I was following earlier on online. And I thought since I'm around, I can come and physically ask my question. I'm called Dr. Ignatius Asasira, and I am a medical officer from Uganda Virus Research Institute. So when I saw the webinar, I was pushed the fact that I'm working on a clinical research that is also around related to epidemics. So my question to Dr. Winters and maybe Prof is about preparedness. During outbreaks, we have done a good job as a country in the previous outbreaks and epidemics. Concerned about our readiness as a country, as an institute, as stakeholders during the non-epidemic periods that puts us at a good leverage. Whenever we have an outbreak or an epidemic, we jump into, I would love to use the word panic mode. And I realized, because I was a little bit involved during the Ebola outbreak, I saw what happened during Mpox. COVID was not any different. And I'm wondering, what more should we do as an institute, as partners, that will put us in a better position in terms of structure, like existing? I know the ICER is already, the ICER Interdisciplinary Consortium on Epidemic Research is already in place, but I feel like there is something more. You talked about community involvement. Right now we have the community health extension workers, and when you interact with them, I mean, the work I do, once in a while I interact with them, you realize that there is still a lot of, for lack of a better word, misinformation around how the country and partners approach, whenever we have an outbreak. People still have a lot of hesitancy. And I'm thinking maybe one of the reasons is because whenever these outbreaks come, they find us when we are not, still for lack of a better word, not well prepared, especially the funding bit. So, but what is within our scope of management as an institute that we can work on now that we are looking at MLI for the next, 100 years or 50 years, expanding? What else should we really put our focus on? Thank you very much.
Thank you, Ignatius. Of course, I couldn't put it better that most of the time when these epidemics happen, adopt a reactionary kind of approach, and that's what we want to avoid. I was on a call, I think yesterday or last evening, and someone asked if another outbreak happened now, an epidemic, are we ready? And for us as ICER and as the Lung Institute, I think we've been trying to change that status quo. And I will tell you that beyond the community, continuous community engagement that we are doing, we have put in place a certain kind of framework for both intra and inter-epidemic activities. And some of that framework, of course, involves being able to implement studies during the inter-outbreak, so that, for example, if there was a study on any medical countermeasure, be able to have evidence to quickly support enrollment or use of such a countermeasure. Another inter-outbreak, which is actually a very important activity, is the community engagement. I will tell you that if you engage the community very well, they will not give you any trouble. The problem we have is the outbreak happens and then you go and plant yourself there. They will chase you. So we need to really engage the community, and that's where we are going to put a lot of our efforts on, because we know you will never handle these epidemics without the community. Actually, most of them start from the community, so you can't avoid the community. Okay. I don't see any other hand, Prof.
I think we'll bring it to a close. Someone has asked, are there any volunteering opportunities? Yeah, I think maybe what Rebecca could speak to this, but since the time is gone, I will try to answer. You could join the Lung Institute family in different ways. One of them is through job adverts, and many people have interacted with us through this mechanism. The other one is to join as a researcher or to join as a clinician. As you saw, we have probably the largest chest clinic in the region. Yeah. So you could join all this. As a researcher, if you don't have a master's degree, you will come as a what? I think as a trainee. Rebecca, am I right? As a trainee. And then once you have a master's degree and above, you have a possibility to join as a research fellow. Now, to become a research scientist, you have to do certain things to become a research scientist. And then you can grow from research scientist to senior research scientist to principal research scientist to chief research scientist, which is an administrative job, which I currently also still hold. So if you are interested to come, please come. You don't need anything. Once you want to be a research fellow, you will be vetted by our ITAC. Remember what Damari showed you, the Institute Technical Committee, and they recommend you and will appoint you. You don't have to be full-time. You can be from any other institution around the country. So if you are from another institution which is employing you, we call you an associate research fellow scientist. And you can say, I'll be at MRI for 20 to 30% of my, no, the minimum is 40, isn't it?
It's 40.
You must be able to give us 40% of your time for you to be useful in the institute. And then you come, write your grants, join discussions, and for young people, probably this is the easiest way to enter MRI. Even as this morning, there was someone in my office. That's what I advise. Become a research fellow, start participating, start working. A project could find you on the way, a PhD, whatever will find you. And most importantly, we mentor you and you'll be able to write your own projects. And it has happened. Most of these people you see here, they joined me as young people, but they are now very big PIs. Over 20-30 of them. So you are welcome. So members, I want to thank you so much.
Prof,
Yes.
I have, I think I've been asked to read out some announcement. I don't know if I should do it now.
Okay.
And I will read.
1 minute.
Yeah, I will read it as it is. I think they knew I would make a mistake, so they wrote it for me. Thank you for attending the MLR Attend webinar series. We appreciate your continued engagement as we celebrate a decade of lung health impact. Please note that we have 2 upcoming webinars this week. On Wednesday, 30th July at 3 p.m., join us for a session on global air pollution exposure and consequences among vulnerable populations with Dr. Stefan Schwander from Rutgers University, US, and Dr. John Sempebwa from the Makerere University School of Public Health. Then on 31st July at 3 p.m., we will host a timely discussion on recent developments in research integrity featuring Professor Jonathan Grigg from Queen Mary University of London, moderated by Dr. Ivan Kimuli from the Lung Institute, and CPD points will be awarded for both sessions. We look forward to your participation as we continue this important dialogue. Over to you, Prof.
Okay, thank you very much everyone for attending. Have a good evening.
Okay, thank you.
Good evening, Prof.
Yeah.
Thank you.